Good afternoon. Thank you very much for the kind introduction. So this is possibly the favorite topic that all of us commonly, irrespective of subspecialty, that we deal with, that is the management of diabetes as well as more focus on diabetic kidney disease. And it's a good opportunity because this week, coming week, I'm starting clinic at Malad West. So thank you Malad Medical Association for this opportunity. This is where at Rolex apartment near New Era Signal. So thank you very much for this. See, this is our textbook case of what we see in our clinic day to day. 55-year-old female, long-standing diabetic, hypertensive, has a diabetic retinopathy. And she's on the following medicine on the right side, like metformin, lisinopril, amlodipine, hydrochlorothiazide. And the limited investigation, what we see is the blood pressure 150 by 90, A1C of 8.5, GFR close to 40, and albumin create ratio is around 780. So we'll hold on to this thought, and maybe in next half an hour we'll see whether we can modify and hopefully prevent her from going on dialysis, or we can possibly slow down her chronic kidney disease progression, because that's what the basic aim to treat the diabetic kidney disease. So this is what altered hemodynamic, what we see in the nephron. We have around 1 million nephrons per kidney. There are afferent and efferent arteriole. What we see is the afferent being vasodilated and efferent is a vasoconstricted, because there is a more and more angiotensin 2 that is being secreted in the kidney. So what we see on the biopsy is a glomerular hypertrophy, hyperplasia, and extracellular matrix deposition. But we as a clinician, what we see in our clinic is the albuminuria. So leakage of albumin, and later on all the proteins in the urine, hypertension, and the decline in the renal function in the form of elevated creatinine or drop in the GFR. So this is a basic hypertrophy. So whenever we are thinking about diabetic kidney disease, we should think as a glomerular hypertension and the albuminuria. Important thing is the third point, there is a glomerular hyperfiltration in the early stage. What is the clinical implication? So by the time creat started rising, what we see in the report, it's already too late. Because the early stage of diabetic kidney disease is a hyperfiltration, so that will falsely keep your creatinine normal. For that reason, we also need to check the albumin creat ratio, because albuminuria often is a earlier marker or the earliest marker to diagnose the diabetic kidney disease. So we need to remember, by the time GFR is declined or we have already seen the rise in creat, it's already, I think, we are running late in treating her diabetic kidney disease. So as we know, there are 5 stages of CKD based on the GFR. Every 5 to 10 years, they like to change the equation and confuse private practitioner. Most commonly, currently, the most recent one is the CKD EPI equation. A lot of labs still, putting the MDRD formula, Cogrod fault formula. That's not correct. So it's easily available on Google, or many calculators are available to diagnose the GFR, that is the CKD EPI. As we know, it's divided into stage 1 to stage 5. Stage 5 is the GFR less than 15. That's when the patient requires a dialysis. And probably around stage 3 that we get more referral to treat her for her chronic kidney disease, developing from diabetes, hypertension, often both diabetes and hypertension. And this is what now if you see all the kidney guidelines, what they have come up with is something called heat map. So on y-axis you see G1 to G5, that is the GFR, glomerular filtration rate. On the x-axis is the A1, A2, A3, that's the albuminuria. So we cannot no longer isolate them. When you see there is the A3, and even if GFR, glomerular stage in stage 3, those are still more prone for developing end-stage kidney disease and cardiovascular mortality and morbidity. So we cannot segregate GFR as well as albumin. We need to take care of the both. So that's why we need to check albumin creat ratio, say every 6 months to annually in the early stage of CKD, and possibly more frequently once the CKD stage advances. So that's where we need to think in terms of GFR as well as the albumin creat ratio. This is what the ADA recommend, when we see the diabetic kidney disease patient, to check the spot urine albumin creat ratio. This has almost has replaced the 24-hour urine collection, because it's cumbersome, logistically difficult. very poor patient compliance. So spot sample also can give us a better idea about their albuminuria. To check the creatinine and GFR as we discussed. And once they are on ACE inhibitor and ARB, we have to monitor her potassium and the creatinine level. So this is our initial visit, and annually. As the stage advances, possibly we may need to check every 3 months to 6 months, depending on how the patient stages are progressing. So, as we discussed the diabetic capital, we are moving towards a diabetic capital, and CKD is major. There are more and more prevalence that we are seeing with the metabolic disorder, mainly diabetes and BP, and we are almost there to surpass China in terms of becoming diabetes capital in the world. This is the green is very important table. Despite your glycemic and BP treatment, the more than 1/3 of your patient will develop CKD, and some of them even 15% will end up on dialysis. So no longer glycemic control, BP control is the only thing. In 2023, we are more moving towards the end organ target damage, that we have to think about cerebro protection, cardio protection, and the renal protection. So diabetes, BP control is paramount important, but that's no longer the goal. So even if you keep them at a glycemic and BP goal as recommended by various society, still 1/3 of them will progress to CKD. And that's why we need a newer treatment to slow down or delay the progression of chronic kidney disease. And more important, CKD is now major risk factor for cardiovascular disease. So it's no longer just about the dialysis and the kidney problem, but CKD is one of the major risk factor for the cardiovascular disease. You see a lot of atherosclerotic cardiovascular disease, as well as another arm of cardiovascular disease, that is a heart failure with either reduced EF or with the preserved ejection fraction. And if you have a CKD and type 2 diabetes, they are 6 times higher risk of cardiovascular disease compared to somebody who doesn't have diabetes or CKD. Where is the challenge? The CKD is still underdiagnosed and often missed. So that's where the purpose, that's where we get major referral from primary care. So that's why we need to diagnose them early and give them a timely referral to have a holistic management of diabetic kidney disease. So this is a basic, pyramid, how we can treat the diabetic kidney disease. At the bottom of the pyramid, as we discussed, glycemic control, blood pressure control, 130/80 is the mostly recommended by all society. If patient is albuminuric or patient is diabetic, the lower is the better, provided they are not dizzy, they are not falling. Lipid management, that is gaining more and more attention. Aerobic exercise, more than 150 minutes, that's 30 minutes a day for 5 times a week. And the protein restriction, because if protein intake is more, that turns into blood urea nitrogen and gives the stress to kidney. So all the CKD patients are salt restricted and the protein are restricted, and the aerobic exercise. When we talk about SGLT2 inhibitor, the blood pressure reduction on those drugs is 3 to 4 millimeter of mercury. Aerobic exercise and the diet modification gives the more blood pressure control, especially salt restriction and the aerobic exercise. So this lifestyle modification we should not ignore, and those should be the first step in your treatment for managing the diabetic patients. Smoking cessation, as we discussed. Most patients should be on RAS blocker, that is angiotensin or ACE inhibitor, and SGLT2 inhibitor. And on the top is the patient who are at a higher risk of atherosclerotic cardiovascular disease. We can decide about the antiplatelet and the statin for them. So briefly, as we first slide we discussed, there is the afferent vasodilatation and efferent vasoconstriction. So that's where the basic pathophysiology. So all diabetic kidney patient should be on renin-angiotensin blocker, either ACE inhibitor or ARB, because that's the class of agent which is reversing the basic pathophysiology. So many times, patients coming with a creatinine of 1.5, 1.8, with the fear that this medicine will raise the creatinine, those are patients are not put on ARB, and that's where we need to change our perspective. So unless there is a hyperkalemia or the advanced stage of CKD, all the diabetic patients should be on renin-angiotensin aldosterone blocker. This class of agent, if you look at cardio, nephro, cerebro, neuro literature, everywhere the RAS blocker has shown the mortality and morbidity benefit. So this is the primary treatment. We get more and more newer drugs, but all these comparisons are always made with the renin-angiotensin blocker. If patient is coming with, say, creatinine of 1.4, that's what we see in primary care, you start the angiotensin blocker. In 1 month, the creatinine is 1.6. And often the practice is to stop the angiotensin blocker, and we should not stop up to 30% of rise. See, basically what we are doing is the afferent vasodilatation. So unless you drop the GFR, the proteinuria cannot go down. So unless you started with the creatinine and there is a more than 30% rise in the creatinine, please do not stop angiotensin blocker. Once we stop, then the patient, all the glomeruli are getting sclerosed. Many times patients are admitted in hospital for say gastroenteritis or for various reasons. That time they develop acute kidney injury. During hospital stay, the ARBs are stopped. And when they go back to the OPD and the setting, these often drugs are forgotten and they are not put back on the RAS blocker. And that's, I think, is a very serious mistake that we are making. And we should make an every effort to see whether they are putting back on the angiotensin receptor blocker when they are no longer hypovolemic, dehydrated, and they are in their stable condition. These were the two papers in 2001 in New England Journal of Medicine which changed the way we look at the diabetic kidney disease. So those were in the ACE inhibitor and ARB, two pragmatic trial, renal and IDNT. And this is the way we started with the angiotensin receptor blocker. So as emphasis is there, all the patient of diabetic should be on renin angiotensin aldosterone blocker. Some of them are Indian diet is more prone, we have a very potassium rich food, and there are patients come up with a 6.5, and we often get references for junctional bradycardia, bradyarrhythmia, because patient on ARB, they took the non-steroidal anti-inflammatory agent, got gastro, and they come to ICU with potassium 7 and go into junctional bradycardia. Many times, advanced stage of CKD, we cannot put patient on renin blocker. What we can do is the second recommendation is a calcium channel blocker. So just a brief 2 slide on there are newer calcium channel blocker has come. What's the problem with the amlodipine and nifedipine? First of all, there is no cardio-renoprotective action, not a primary endpoint. They are very good blood pressure controlling agent. What they do, they call the reflex sympathetic activation. So they are more for reflex tachycardia. And obviously, we know the side effect of the pedal edema with the calcium channel blocker. So there are 3 types of calcium channel. L, when we talk, it's a traditional. N and T are the newer calcium channel blocker. So what they are doing, N type of channel blocking decreases your glomerular pressure. Again, our main basic pathophysiology of diabetic kidney disease. T type of channel blockage decreases the aldosterone. That is also the basic pathophysiology. So briefly, if you look at the older nifedipine and amlodipine, those are classical L-type blocker. Cilnidipine, that's where the name comes from, L and N type of blocker. Benidipine blocks all the 3 types of channel, and ifosfamidipine and azanidipine blocks the L and T. So you can use your judgment to try this newer calcium channel blocker. We don't have and possibly will never have a head-to-head comparison with the traditional and the proper randomized controlled trial, but in selected patient or addition to RAS blocker, we can use this calcium channel blocker to help the proteinuria or get a better blood pressure control. Going back to glycemic control, so what oral hypoglycemic agent should we choose? Metformin, our oldest friend. Up to GFR less than 30, we should not stop. The GFR till less than 30, we should not stop metformin. Many times creat is 1.52. Often we reflexly stop metformin, but there are newer and newer data. The risk of lactic acidosis with metformin is very negligible. It was with the previous fenformin agent that was available, and SGLT2 inhibitor. And we can choose the lower oral hypoglycemic agent for better glycemic control. Possibly SGLT and GLP-1 are making more and more news in terms of CKD progression retardation. Briefly, as we know, there are multiple. In SGLT2 inhibitor, only one thing I will find the contraindication. That's the one class of agent in last few years, there is almost always a positive trial. I really want to see one negative trial with the agent. You take any cardio, nephro, any literature and SGLT2 in CKD, diabetes, heart failure, everywhere there is a positive agent. So always, if you have to choose oral hypoglycemic agent along with the metformin, the first should be SGLT2 inhibitor, and then you can go to the subsequent addition in choosing the oral hypoglycemic agent. As we know, there is a risk of hypoglycemia, so mainly sulfonylurea and insulin dose that needs to be adjusted. Patient should, if is a hypovolemic or dehydrated, and we should cut down the diuretic dose provided patient is not in the heart failure exacerbation. This is just a brief, if you look at the pink, so patient is on placebo, then the drop in the GFR every year with diabetic kidney disease is almost 5 ml per minute. If patient is on SGLT2 inhibitor along with the RAS blocker, you can really slow down the GFR decline almost by 3 ml per minute. So this is just a hypothetical example. So by giving RAS blocker and SGLT2 inhibitor, you are giving 15 years of dialysis-free health to the chronic kidney disease patient. So that's what the impact the RAS blocker and the SGLT2 inhibitor have made in the diabetic patient. So always find the contraindication. If you don't find contraindication, make sure to put them on a SGLT2 inhibitor with the appropriate dose as mentioned in the previous slide. So this was the first, want to focus on the lower part, the residual risk. So when we added the renal angiotensin blocker, so even if you put patient on renin angiotensin blocker, still the gray area portion, patient will end up on dialysis. If you add SGLT2 inhibitor, as you see, the residual risk has gone down significantly. Do we need any other disease? We have a renin angiotensin good agent, we have a SGLT2 inhibitor, but still as we see, still there is a gray area. Still we are not giving a dialysis-free opportunity to the diabetic kidney disease. So do we need any other agent? So this is a basic driver of CKD, hemodynamic, high blood pressure, glucose. Second is a metabolic, as we know, the poor glycemic control. Many times you have seen that, like, there are 10-year-old diabetic and suddenly they come up with a 7 gram of proteinuria. We do all glomerular nephritis workup and everything is negative. When we do biopsy, it's a diabetic nephropathy, but we see a lot of inflammation, a lot of lymphocyte and a lot of fibrosis. Every diabetic phenotype behaves differently, and unless we do biopsy, we don't pick up those inflammation and fibrosis. So all these available agents are focusing on hemodynamic and glycemic control. So far we don't have any agent to counteract the inflammation or the fibrosis. So that's where, like, the newer treatment can come into the picture. So as we see, RAS blocker, diuretic, calcium channel, SGLT2, they are affecting the hemodynamic parameter. We have multiple agents available for glycemic control. So for inflammation and fibrosis, where there is a mineralocorticoid receptor activation, as we've seen, there is a newer molecule in last about year or a half. We have seen the newer molecule that is finrenone. So it's a novel, non-steroidal. This is like similar to spironolactone, but spironolactone and eplerenone are steroidal molecule. This is a non-steroidal molecule, and it's a very selective mineralocorticoid receptor antagonist. So just to compare the three agents that in the similar class, so it's a potency against the mineralocorticoid receptor it's a very selective agent. It's a non-steroidal molecule, so sexual side effects like gynecomastia are not much with the finrenone. Half-life is very short, so it can wash out. If you develop hyperkalemia, if you stop, then within, say, day or two, you can bring down the potassium. And the effect on BP is very marginal. If you see spironolactone, we often use in the resistance hypertension, but finrenone is not very strong antihypertensive effect. Sometimes it's very helpful because you are already putting patient on RAS blocker, you are adding SGLT2 inhibitor, and on top of that, we can use the finrenone to delay the progression. If you look at in terms of data trial, so maximum, if you take at the patient, so the finrenone has a maximum data in terms of number of patients on the randomized control trial. So finrenone is already approved in India and is mainly for diabetic kidney disease, not for hypertension and CKD. SGLT2 inhibitor is for diabetic as well as non-diabetic CKD. So if you have a patient with chronic kidney disease and even if he doesn't have diabetic, you can still put them on SGLT2 inhibitors. So briefly, I'll just go. It's available in the 10 milligram and 20 milligram. It's a once a day dosing. What we have to monitor is like any other renin angiotensin blocker, we have to monitor the potassium level. If creatinine level is going down, creatinine level is going up, we need to cut down in the dose of finrenone. So briefly in summary, so 3 pillars of therapy to reduce cardiorenal risk: RAS blocker, SGLT2 inhibitor, and non-steroidal mineralocorticoid receptor antagonist. Like if a patient is presenting with heart failure, reduced EF, we have often seen cardiologists like, putting them on beta blocker, SGLT2 inhibitor, RAS blocker. That's the way we have to think in terms of diabetic kidney disease. Those are not complementary or those are not alternative to each other. Gradually we need to put them on all the agents sequentially to give them a maximum benefit to retard the progression of chronic kidney disease. This is just a brief summary of snapshot of what we discussed in the diabetic kidney disease patients. Thank you very much.
Thank you, Dr. Paras, for such a wonderful session. I think this session will be very useful in our clinical practice. So really, and the slides were very informative. I now request our President-elect, Dr. Hemal Maniyar, and Treasurer, Dr. Aarti Vyas Madam, to felicitate, sorry, my apologies. I request Dr. Naresh Dandekar and Dr. Moini Velapurkar to please felicitate our speaker, Dr. Parekh.